Pancreatitis in dogs is in many ways a humbling disease. It may start mild, perhaps with just some low-grade vomiting or lethargy, but it can progress rapidly and sometimes without warning. And it is that unpredictability that makes it so challenging and why it demands more than just a traditional approach in some cases.
Hey guys, welcome back to another episode of Vetfolio Voice. This episode is sponsored by SIVA and features Dr. Harry Cridge back on the podcast to talk about one of those conditions that really seems to keep us on our toes, no matter how many times we've seen it, how many times we've managed it. That's right, we're talking about acute pancreatitis in this episode. And acute pancreatitis can be really frustrating because, as we'll talk about in this episode, it's rarely straightforward. Sometimes we'll get a patient with some mild GI upset and inappetence, and other times it'll be this extremely painful and life-threatening condition. And in either of those presentations, there's not really a single test or a clear-cut approach to obtaining a definitive diagnosis, nor is there a one-size-fits-all approach to management. And how do we talk to clients about what to expect both in the short term and in the long term with a condition that demonstrates so much variability? I don't think anyone understands that variability and all of the questions that it can create better than Dr. Harry Cridge, who is continuously working to learn more about this elusive disease to provide more evidence-based recommendations and help give our patients the best possible outcomes. I am not even going to start to list what we talked about in this episode because, as you can imagine, we covered a ton of information. So I will stop my comments there. Let me tell you about Dr. Cridge and we'll jump in. Dr. Cridge is a dual American and European board-certified specialist in small animal internal medicine. He has clinical and research interests in gastroenterology and disorders of the exocrine pancreas. Dr. Cridge is a subject matter expert on pancreatitis and EPI and routinely publishes and lectures in these areas. He's also a senior editor on an upcoming textbook focused on disorders of the liver, exocrine pancreas, and gastrointestinal tract in dogs and cats. He currently serves as an associate professor of small animal internal medicine at Michigan State University College of Veterinary Medicine. All right, let's go ahead and jump in.
Join more than 100,000 learners just like you. Vetfolio is one of the largest providers of continuing education for the animal health community, offering more than 500 RACE-approved CE courses. Earn veterinary CE anytime, anywhere with Vetfolio. Subscribe today at vetfolio.com.
Well, I'm super excited for this episode to be joined by Dr. Harry Cridge. And Dr. Cridge, we've talked about pancreatitis before, but I am really thrilled to be talking about it again because, I don't know, it can be a tough disease process to kind of nail down and figure out what it is we're supposed to do with these cases.
Yeah, absolutely. I think it's, the gift that keeps on giving. It's a very challenging disease process, in terms of how it works, how we diagnose the disease and how we manage it. But they can be really, rewarding cases. And, it's an exciting time in the world of pancreatitis. We've got more treatment options than we ever have, and we're really excited about the future.
Absolutely. I feel like I say that a lot. Like, what a time to be a veterinarian.
hmm
There's so many disease processes where the research is just expanding so rapidly and what we know. And lucky me, I get to be on the front lines in this way and talk to people who know way more than I do, like you, about how we use this knowledge and these resources and this data to do a better job for our patients. So along those lines, you mentioned kind of new treatments and things like that. Diagnosis, though, just kind of figuring out what it is we have on our hands can be one of the big challenges when it comes to pancreatitis. So, can you talk to us about kind of, is there an optimal approach for diagnosing pancreatitis?
Yeah, and this is, a question that always gets brought up with pancreatitis is, how do we best diagnose these cases? And I think a lot of that goes back to, how this disease was defined historically, and it was defined by histopathologic features. But we all know that's not feasible for the majority of our acute onset cases because they're poor anesthetic candidates. It's expensive, it's invasive. But what that means for us as veterinarians is we're sort of put in the driver's seat, which is good in the world of AI. We're irreplaceable in, putting together all of the clinical data we have to come up with the most optimal diagnosis for our patients. And under, the ideal scenario, that includes assessment of the clinical histories and clinical signs of these patients, looking at some level of imaging with the most common modality being abdominal ultrasound, and then combining that with a pancreas-specific lipase test to come up with that overall clinical picture about what's going on, and then integrate that into ongoing therapies.
So it sounds like, which has certainly been my experience when it comes to pancreatitis, the diagnosis is really we're obtaining this in a multimodal kind of way. We're talking about imaging and blood testing and really combining that with the patient's history and clinical signs and using all of that together to form this clinical picture and make this diagnosis.
Yeah, absolutely. And it goes back to the fact that there's no single perfect diagnostic tool. So as a clinician, we have to know the limitations and the benefits of each technique and apply that together to come up with the most optimal answer. We would all, love to be in a world where there's, one single test. It would make our lives much, much easier, but that's not the reality of pancreatitis right now. And that's why, the more pieces of data we have, the more confident we can be in that diagnosis.
Sure. Oh gosh, if only we could just run the pancreatitis test. That would be so nice. But kind of thinking about this multimodal approach, we run into limitations when it comes to running these different tests sometimes, whether it's financial or patient compliance or whatever the case may be. And so sometimes we have to rely more heavily, say, on history and clinical signs than one test or another, or vice versa. So, how should we think about pursuing diagnostics? Like, do we need a definitive diagnosis every time? Is it reasonable to treat off of clinical suspicion?
Yeah, and I think that's a great question. And, certainly in the world of academia, it's very easy to say, we should do X or Y because that's the gold standard. But we all know that we all operate in different environments across the country, and we all are faced with these financial and logistical limitations to our practice. But that doesn't mean that we can't do a good job. And there's certainly lots of really good things we can do at the patient side. So the way I typically think about this is instead of focusing on the disease or the disease we think is going on, focusing on the patient. So having that patient-focused approach. And, for example, if we have a first-time offender with mild clinical signs and we are in one of those scenarios, perhaps our main priority in those cases is going to be ruling out diseases that need to be treated differently. So most commonly for me, that's ruling out the foreign body with the radiographs. So focusing on what clinical question do I need to answer for the patient in front of me? And if that is the scenario we're in, then we can treat based on that clinical suspicion and the lack of something that we need to treat differently. But if we're in another scenario, for example, we have that repeat offender or a dog with severe clinical signs, to me, that's a scenario where we may want to lean a little bit more into those diagnostic tools to make sure that we're treating the right disease, we're not missing something, and hopefully make sure we're confident in it being able to prevent that disease again in the future. So I think it's really scenario specific as to how much of that diagnostic confidence we need. Certainly in the research world, in other worlds, we want as much evidence as possible, but answering the questions that the patient gives to us is going to be our top priority as a clinician.
And, I always find those kind of approaches really empowering as a general practitioner to say, look at the patient in front of you and use your clinical judgment on how far we need to go down the diagnostic route in this particular patient and what the best approach is for that specific case.
Absolutely.
So let's, however we get our diagnosis, when we land on a diagnosis of pancreatitis, generally, when we've talked about treatment in the past, we've talked about, it's a lot of symptomatic care. So can you talk about what our approach to managing pancreatitis has been up to this point?
Yeah, so absolutely. As you mentioned, the way that we've traditionally approached these acute pancreatitis cases in dogs has been focusing on providing supportive and symptomatic care and allowing the body time to recover and to return to normal health. And that has worked for many cases, but the challenge is we've all had those cases where, the patient has significant morbidity or even potentially mortality when we're relying on just those supportive and symptomatic measures. And when we talk about that traditional approach, we're typically thinking about things like fluid therapy, nutrition, antiemetics, and pain relief medications. That's been sort of the caveat of the majority of pancreatitis cases for many decades at this point.
And not necessarily in that per acute period, because usually they're not really thrilled about eating and everything right at the beginning, but hopefully sooner rather than later, working on dietary therapy, which we've generally focused on a low fat diet in those cases.
Yeah, so let's take a moment and talk about nutrition and
Yes,
pancreatitis.
let's
It's a
do that.
really, an important and exciting topic. One of those things that has undergone, significant changes over the past several years, with now focusing on trying to get nutrition into these patients as early as we can to keep those intestinal cells happy, to try and reduce risk of translocation and other potential consequences of withholding nutrition. And in that acute phase, depending on the type of practice and the facilities that you have, we may be talking about placing feeding tubes, or we may be talking about, other ways to optimize voluntary food intake, whether that's providing adequate analgesia, controlling nausea, providing warm foods, and on other things that we can do if we don't have the ability to place those feeding tubes to encourage that return to voluntary food intake.
Sure. I love the early enteral nutrition for GI diseases. It used to just like hurt my soul to withhold food if I felt like they were starting to get a little bit better. So I love the idea of keeping nutrition in these patients. To me, it just, I don't know, maybe because of how much I like food, it just makes sense. I don't want to withhold food if I don't have to. I'm really curious to know, since you mentioned feeding tubes. I love an esophagostomy tube. I feel like they're fairly easy to place and maintain, and we can get different types of diets through those tubes. Do you have a preferred method of feeding in an inappetent patient who you feel like would benefit from a feeding tube?
Yeah, and ultimately, to me, the question on the type of feeding tube is really gonna come down to what you're comfortable with in practice. So here we place a lot of nasogastric tubes. That's just sort of institutional familiarity. And the benefit of those or nasoesophageal tubes is, they're relatively inexpensive. They can be placed under sedation. We don't need to anesthetize these patients. And, they can be removed relatively easily. The challenge with them is they're typically considered more shorter term feeding tubes, and they typically have a narrower lumen than, the traditional like E tube. So we often have to place, slurry diets or liquid diets down those. Again, most of the time in that acute phase, focusing on lower fat diets where we can, with the caveat being that there's likely a little bit more to pancreatitis than just low fat, but that's sort of some of the evidence we have right now. So that's what we tend to stick to in the acute phase of disease. But longer term, the question becomes, do we have to keep those patients on those low fat diets or not?
Oh, is that a new? Now I want to know, like, do we keep them on a low fat diet? I'm guessing, running it through my own head, it seems like it would be patient specific of, if you do have that acute case, mild signs, first time offender versus a chronic reoffender that is having more severe clinical signs is where my mind goes. Am I on the right track there?
Yeah, absolutely. So again, we're going back to, treating the patient in front of us and being cognizant of some of the costs associated with doing prescription diets and other things. So for me, there's not a lot of studies right now on long-term feeding of these pancreatitis patients. It's something that I'm hoping to do some studies on in the near future. But for me, the way I make the decision is in the acute phase of disease, I typically will do a low-fat diet until we have data to say that we shouldn't. I also measure serum triglyceride levels because we know that high triglyceride levels are a predisposing factor for pancreatitis in dogs. So if I have a dog that is hypertriglyceridemic, that's going to be a dog that I'm really focusing on not only controlling the pancreatitis, but also controlling those triglyceride levels. And the first part of that treatment is going to be a low-fat diet. So if I have a dog with pancreatitis and a high triglyceride, typically above, 600, 700, I'm going to be really emphasizing to that owner the importance of a low-fat diet. In contrast, similar to what you said, if I have a mild case and a first-time offender and the triglycerides are normal, and the owner has, some financial limitations or the dog is on a diet for another comorbid disease, then maybe that's one where I'm not going to focus as much on, markedly restricting that fat content and just trying to stick with a more typical fat while still avoiding really high fatty foods.
And I know I'm going off on a tangent here, because I'm really curious about nutrition. So I promise I'll get back on track here. But I did have one other question about the nasogastric or nasoesophageal tubes, because, like you mentioned, these do tend to have a much narrower lumen. How is that for getting low fat nutrition into patients in that acute period? Are we able to get those diets through those tubes?
Yeah, so some of the commercial liquid diets can go down those tubes and they have a decent caloric density. So that's that they can go down the nasoesophageal or the nasogastric tubes. If we are in a situation where we're, not using one of those foods and we're blending foods or, we're doing other things to the diet, sometimes that can be a limitation. And that's where, people that are comfortable with the e-tubes or a scenario where, we don't have a lot of money for hospitalization, some people will prioritize placing that e-tube to help in the nutrition in the at-home environment too, because typically nasoesophageal and nasogastric tubes, we're going to be in charge of those in the hospital, and then they're going to come out. In contrast, that e-tube is something that we can send home. So I've certainly been in scenarios where we've been financially limited, and we know that a big component of this particular patient's presentation has been inappetence. So that's sometimes a question of, do we put money towards more prolonged hospitalization, or do we put money towards making sure this animal's getting nutrition and support in the at-home environment? And that's often a case-by-case decision.
Well, thank you for going off on that tangent with me. I feel like I learned a lot there about nutrition because it does seem like it's an evolving piece of management when we're talking about pancreatitis. So, yeah, I'm looking forward to seeing what some of these longer term studies and what we learn in the future.
Yeah, and I think on the front of the nutrition, trying to get those serum triglyceride levels, in these pancreatitis cases, we are somewhat limited in veterinary medicine in the fact that they're not on all our routine chemistry panels. So it can be overlooked and it can be missed. So if I have sort of one caveat for the audience is, if we have those pancreatitis cases, particularly those repeat offenders, trying to submit some of your extra serum for a triglyceride concentration can be really helpful in deciding where we go with management of these cases.
Sure, absolutely. I actually had a case like that not too long ago that I remembered from our previous
Yeah.
conversation talking about the high triglyceride levels. It was two dogs, same household, they were related, upwards of 1,000.
Wow.
And yeah, they were okay. They were non-clinical, but we did make some adjustments to what they were eating at home, and it made a huge difference. They came down, I want to say they came down into the normal levels here recently.
Awesome. That's incredible. Great.
Yeah, yeah, that was a really rewarding one. Okay, so we've talked about kind of our quote unquote traditional approach to managing pancreatitis with fluids and antiemetics and analgesics and nutrition and things along those lines. But certainly we have some newer therapeutics as well. For example, Panoquell-CA1. So what does the data support in terms of essentially when do we incorporate something like Panoquell-CA1?
Yeah, so Panoquell is a really cool novel therapeutic. It's designed to limit sort of the amount of neutrophilic inflammation, and it's been shown to improve the clinical signs associated with the acute onset of pancreatitis. So this is sort of, where we move from the more traditional supportive and symptomatic care to one where we can deliver more targeted therapeutics to our patients. And in terms of, where we can use this medication, the way it has been studied to date is there was a randomized control, placebo-controlled clinical trial that looked at, patients with suspected pancreatitis, and they were randomized to receive either supportive and symptomatic care with a placebo or supportive and symptomatic care with Panoquell or fuzapladib sodium, which is the active ingredient in the drug. And that's the environment it was tested in. So it's designed to supplement that supportive and symptomatic care that we've traditionally utilized. And in those environments, that's where it's been shown to improve the clinical signs associated with the onset of pancreatitis in those dogs.
So incorporating it into our pre-existing symptomatic and supportive care plan is really where Panoquell-CA1 tends to shine.
Absolutely. So it's designed to be utilized alongside those other medications, and it's designed to be an additional component where we target in more specifically and adding to the efficacy of that treatment and improving those clinical signs of pancreatitis in our dogs.
That makes sense. And you mentioned that it reduces neutrophilic inflammation. Can you talk about that a little bit more in terms of mechanism of action?
Yes, it's actually a really interesting drug in the way that it works. So it's an injectable medication, and it's designed to inhibit something called LFA1 or leukocyte function associated antigen 1. And if we think all the way back to vet school, that's a specific receptor that's involved in the movement of neutrophils from the blood vessels and into the tissues. So by blocking activation of LFA1, it effectively blocks and limits the movement of those neutrophils from the blood into the tissues. So thereby reducing the amount of neutrophils in the tissues and thereby helping to control inflammatory conditions such as pancreatitis.
That's so cool.
It's a really cool novel therapeutic, and it's exciting that it has been shown in those trials to help our pancreatitis dogs.
Absolutely. I mean, some of these, especially some of these really severe cases, it's like anything and everything that will help them, we'll take it because I think that's one of the things I find most challenging about pancreatitis is the range of symptoms that we can see. We can see mild vomiting that just needs some outpatient supportive care, all the way to the hospitalized cases that you're talking about that, like you said, sometimes go all the way to mortality. So, anything and everything that we have available to help manage these cases and I don't know, maybe make them a little more predictable sounds positive.
Yeah, absolutely. And it's almost like a humbling disease. It's a
Yes.
disease that, can start mild and progress. And that's sort of one of the things that I'm very cognizant of as somebody that's, dedicated my early career to the improvements in pancreatitis is even, when we treat these cases all the time, we can be surprised and we can be humbled. And that's another reason to me for pushing towards these extra therapeutics so that we can try and control those and make sure we can provide those optimal outcomes for our patients.
Sure, sure. So thinking of Panoquell-CA1 in a clinical case scenario, can you kind of walk us through how we would incorporate this into our treatment plan?
Yeah, so the medication itself is an injectable medication that comes from the manufacturer in a multi-dose vial. So it's injected once daily intravenously for 3 days. And it's dosed at about zero point 0.4 milligrams per kilogram, which when diluted appropriately is zero point 0.1 mils per kilo. So nice and easy math at the patient side, which is really helpful in those busy cases or when you are running a regular schedule and you have the add-on sick patient. Hopefully that little bit of math makes it a little bit easier for in our days. And as I say, it is given injectably, given once a day. One of the questions that often comes up is, do I have to give this in hospital? Can I give this at home? And when we look at the way that the drug is labeled, it's labeled for intravenous use. So it doesn't necessarily mean it has to be utilized in hospital. We have recently done some work looking at whether this can be used on an outpatient basis, and we give that first dose in the in hospital environment, and then we follow up on day 2 and 3, sort of on an outpatient basis. And the majority of those dogs did very well. So not being a 24/7 facility doesn't limit you. You certainly can still use this medication in both environments. Sometimes in clinical practice, we have to be, imaginative and come up with solutions to challenging scenarios. And that's sort of, what's exciting is hopefully in the near future, we'll have some data on it in its use in an outpatient setting. But we are really trying to study these dogs with pancreatitis in more and more environments that will truly reflect what's going on in practice rather than what's going on at the referral level where, perhaps we have less limitations to our practice.
And I love that you bring that up because I'd love to hear more about what you're looking at in terms of outpatient management because in so many of these cases it would be ideal if we could hospitalize, but it's just not always an option. So I love that there's research looking at outpatient care for pancreatitis. Can you tell us more about that?
Yeah, so I can't go into a lot of the specifics while the data is in sort of in progress, but I think one of the things that's really important and that's something that we're doing a lot better in veterinary medicine in recent years is looking at that, that spectrum of care and looking at, what do we do in scenarios that are outside of the textbook case of perfection, which is not the world that we live in. So we did a small pilot study that looked at dogs with clinical signs of pancreatitis and elevated lipase concentrations, and we looked at how can we best support these cases in an environment where hospitalization is not permitted for financial or logistical or other reasons. And one of those components of that therapy was the Panoquell-CA1 with the thought being that we want to try and get these patients feeling better as fast as we can. And that's, one thing that Panoquell may help us with. It's been shown to improve those clinical signs of pancreatitis. So if we could utilize that, maybe these animals that perhaps linger a little bit longer in the outpatient setting can get a little bit better. So we're studying it in that environment. We're hoping to have data out to clinicians, hopefully in the not too distant future, so that we can really see how we can best match our treatments to the patient rather than, forcing our patients onto, the textbook therapies that are out there.
No, and that's incredibly helpful because it is such a humbling disease. I couldn't agree more. It's one of those where, you're going through your day and you're like, I've got this. I know how to treat these things. And then, one of those cases comes in, you're like, I know nothing. So one of the things we've talked about a little bit here is pain relief in these patients. And I know, in general practice, that can certainly be a challenge that we come across if we don't have the option for round the clock pain medications or something like that. So thinking certainly in terms of pain relief, but just in terms of our supportive care in general, what is the data supporting currently versus what maybe are we saying isn't as helpful?
Yeah, so let's focus on the pain relief or the analgesic aspect at first. And in that area, the gold standard would be to use opioid analgesia. And that's because we know that it provides strong and reliable pain relief. And other medications that we traditionally use for pain relief, like non-steroidal anti-inflammatory drugs, are considered contraindicated because these patients already have GI signs, they may be dehydrated, and we have an increased concern that adding in one of these NSAIDs could, hurt the kidneys or hurt the GI tract. And that's why we tend to avoid those type of medications in these dogs and focus on opioids. But even within the realm of opioids, we still have to apply that to our cases. So those cases that are more severe are going to be cases that we focus on the full mu opioid agonists. So things like fentanyl or methadone to provide that really good analgesia. In contrast, those more mild to moderate cases, they're cases where we may get away with, partial mu drugs or other therapies to help provide that analgesia.
So I think I know the answer to this, but I'm curious to know if I'm on the right track. When I think of a full mu, of course we're going to get better analgesia in most cases, but I do, my mind does a little bit go to, are we going to slow GI motility? And I think the answer is the pain is more of a concern for slow GI motility than the opioids. So go ahead and go for the full mu if they're really painful. But is that on the right track?
Absolutely. And you've come across some like absolute real great questions in the realm of pancreatitis because we always fight with that of, we want our therapy to be the most benefit to our patient. And with that, we have to balance our adverse effects. And one of the big offenders in terms of adverse effects in pancreatitis is that of ileus, because, if our patients develop ileus, they're the patients that at least subjectively tend to stay in the hospital a little bit longer, or they may have an episode of regurgitation or something else that could lead to a secondary consequence, such as aspiration pneumonia or aspiration pneumonitis. So we are really balancing dose and effect. And I think one of the things as clinicians is that means that sometimes we're, cautious to use these medications because at first do no harm. And that sort of tends us to lean away from some of those medications. But one of the things we have to be cognizant of, like you mentioned, is ileus is multifactorial. One of the things that can cause ileus is absolutely excessively high opioid doses. But similarly, inadequate pain relief and pain in the abdomen also causes ileus, as well as electrolyte abnormalities and various other factors. So for me, I get these patients on our full mu agonist when they're painful, and it's my belief that the pain relief effect is more beneficial than any ileus effect of the medication. But because of that, and because it's really hard as a clinician to know, what is going on in that GI tract, I tend to use a medication with a shorter half-life, which is I tend to use fentanyl over methadone, which is, somewhat controversial in the world of pancreatitis. But the reason I do that is I can titrate the dose up and down relatively quickly. So I can then see, if I titrate up, is that beneficial for that patient? Or if I titrate down, is that beneficial for that patient? And especially those critically ill patients that are, poorly responsive, it's really hard for me sometimes to know, is this ileus from pain or is this ileus from too much opioid? And being able to change my plan and adapt to the patient quickly becomes my priority. And that's why I pick fentanyl in those environments.
Sure, that makes a lot of sense. Short acting, and when you're running it as a CRI, you can kind of exactly what you said, titrate up and down and really figure out what's going on with that patient. That is helpful both in terms of how we think about our approach to analgesia, but also just when we do feel a little bit foggy on is this ileus from pancreatitis or are we giving too much opioid and how do we balance that? That's a natural question to have and one that we all have to answer. There's not a perfect answer to that question.
Absolutely. And I'll be honest, is, many times, working in an academic hospital where we have, interns and residents and students, and we'll all be around that same case. And, we might have multiple opinions on, do we think it's ileus from pain? Do we think it's ileus from drugs? And I don't think there's, anybody that knows the answer with perfection. And that's why to me, I'm comfortable with doing a dose titration and a shorter half-life drug and working out if we're correct or if we're not, and if not, adjusting appropriately. But the question of analgesics in pancreatitis is a big one. We are doing some additional studies right here at Michigan State University looking at opioids and adverse effects, particularly in GI transit time, and whether we can use other medications like local blocks or other things like that to help control pain. So it is an area of active research. It's hopefully, again, something that, I don't want to leave too many. We're trying and we'll get you some more data soon, but it is an area that's really important to us here and something that we are actively working on.
Very cool. Gosh, I can't wait to see what that research shows as well. What a time to be a
Yeah.
veterinarian. So I'm a little bit afraid to ask about this one, but I feel like as a general practitioner, I need to know what do we know about gabapentin when it comes to these cases if we're talking about outpatient analgesic therapy?
Yeah, absolutely. And I think one of the challenges we have, right, is we've all known sort of opioids is the ideal therapy for these dogs with pancreatitis. But when it comes to the outpatient setting, what do we do for analgesia? And as clinicians, we're all just, doing our best each day. And sometimes that means reaching for what is available. And that's just things like, gabapentin. Some people will think of things like codeine. And it is, some of the things that are available and some of the things that may be beneficial, but we don't have a lot of evidence to support their use. And I think that's, again, another realm when we're looking at spectrum of care where we need to look more closely at better ways to provide analgesia on an outpatient basis. And that study where we mentioned about Panoquell on an outpatient basis is looking at some more novel analgesic approaches that will help provide better analgesia on an outpatient basis to these dogs. So when I think about the outpatient pancreatitis, the two things that come to my mind as, potential limitations or things that really need to be improved on is one is, subjectively the patients get better slower. So thinking about things that can make the patient feel better faster, and that's sort of where Panoquell came into that study design. And then the other thing is, how do we feel comfortable sending these animals home and making sure they're getting adequate analgesia? And that's the other component of that study that hopefully we're going to have data in, hopefully by later this year, so that people on the front lines can really know what evidence we have to support various different therapeutics.
Oh, I can't wait to hear about that because now I want to go all down all the rabbit holes here and talk about fentanyl patches and all these different
Ah,
things. But I
absolutely.
know that we'll hear more, coming out soon. So really looking forward to, all of that data becoming available and hopefully having a conversation about what that study showed and changes we can make in our management plans to pancreatitis to, like you said, to really benefit our patients who can be challenging to manage.
Yeah.
So I will like hold myself back from going down all the analgesic rabbit holes until your study becomes available and we know a little more.
Yeah, and I think, for the meantime, while we're waiting on that additional data to be out there and fully reviewed, is, thinking about what options we have today. And when we think about that, you're correct in that we have gabapentin as sort of one of our oral options that may provide some benefit. So, we just don't have a lot of evidence behind it. But in the absence of other options, sometimes that is a medication that we will utilize. And it is something that I utilize in some of these outpatient patients, particularly before this other study came around. And then the fentanyl patches. I do think fentanyl patches are good for these cases. with the caveat being that they typically take about 12 to 24 hours to reach full therapeutic effect, and particularly in these dehydrated dogs. So sometimes we may have to provide some level of intermittent analgesia, if that's you keep the animal in the hospital during the daytime, and then, by the time it gets home, its fentanyl patch is effective. But just being cognizant of some of those limitations and working around those with what we have available to us right now, while we're all sort of wait with bated breath for the future of research and things that we can bring to these patients.
Sure, sure. That is good to know that fentanyl patches can be a good option in some of these cases. And then we'll have more options ideally in the future. And really, I think that's one of the biggest challenges we face in many conditions that we manage on an outpatient basis is how to provide effective analgesia outside of the clinic.
Yeah, absolutely. And it's something that, again, we're working on something we're really, really excited to be, part of the solution to a really big need in practice.
Absolutely. Yeah. And of the things that need good analgesic care and are a major challenge when it comes to outpatient therapy, gosh, I mean, I can't think of one that is more challenging than pancreatitis.
Absolutely.
Well, Dr. Cridge, as always, this has been a fantastic conversation. I always learn so much when I talk to you. And like I said, I'm really hoping we can talk again in the future and learn more about the study that's under review right now. But thank you for joining me. Are there any final thoughts you want to share?
No, I think that my last sort of parting comment would be to encourage clinicians to feel comfortable in managing these cases in the best scenarios they can. We all know that there's a gold standard, there's the way that we teach in vet school, but there's a lot of ingenuity out in practice, and there's a lot of people doing really, really great work to help support these cases in cases where there are limitations and feeling comfortable, moving beyond these supportive and symptomatic cares, engaging these new therapies such as Panoquell really allows us to have the beneficial effect to our patients. So feel comfortable, reach out, and know that, with time, more and more research is going to be available, and we're going to continue to improve outcomes for our patients.
Absolutely. What a time to be a veterinarian.
Absolutely.
Well, it's still a confusing disease, both in terms of diagnosis and treatment and presentation, but I hope that episode helped clear up some of the questions that circulate around diagnosing and managing acute pancreatitis. Dr. Cridge, thank you so much for joining me. This was such a great talk. I want to say a big thank you to Siva for making this episode possible. And of course, thank you to everyone who joined us. If you enjoyed this episode, please leave us a 5-star review wherever you get your podcast to help other veterinary professionals like you find this and other great content we try to put out there. If you'd like to hear more, you can click on the Education tab on the Vetfolio website or find us wherever you get your podcasts. Of course, we would love to hear your input on this episode as well as ideas for topics for future episodes, so feel free to reach out to me at dvm@vetfolio.com. We can connect on Facebook at Dr. Cassie DVM, or you can find me on Instagram at dr.cassie.dvm. And remember, if one animal is better off because of you today, it's a great day.